Thanks, Ralph. It's a real pleasure to welcome Fred Piel, who's a colleague in the Faculty of Medicine, School of Public Health at Imperial College, and one of the leading experts on the global epidemiology of hemoglobinopathies, and is going to talk to us today about some of the work that he's done on aspects of hemoglobinopathies worldwide, and also the progress towards developing newborn screening programs in low resource countries. So Fred, thanks very much for joining us today.
Thank you very much, Mark, for the introduction and for the opportunity to speak today, and thank you very much to all of you who joined today. So as Mark said, I've worked for the last 15 years on the global epidemiology of hemoglobinopathies in general, particularly on sickle cell disease. But the presentation today is also looking at newborn screening, particularly with point of care testing devices. And that's quite exciting to cover because there is a lot which has been going on in the last few years. I thought, rather than zooming in from or starting globally and then relating it to the UK, because you're probably, most of you are based in the UK, it was probably easier to start with the UK and then zoom out to the global epidemiology. So what I'm particularly interested in as an epidemiologist is key epidemiological indicators of that we can monitor over space and time. So, for example, looking at birth prevalence, and in the UK we are very lucky because we have the universal newborn screening program, which has been in place for a long period of time. So that's a really useful data set, and it allows tracking how things evolve year on year. We can look at prevalence, and that's a lot more difficult because it relies on the number of patients and the total population of a given region or country. And it's been very difficult, and I'll come back to this later on, to sort of quantify the exact number of patients in various countries, including the UK. So nowadays there is the National Hemoglobinopathy Registry, the NHR, which a few years ago was probably not very complete and was at the early stages, and nowadays is a lot more reliable and a lot more complete, so a much more stable resource. And then there are other aspects that we are all interested in, which are in relation to mortality, survival, how many of these patients are dying, at what age, and what are the factors improving their survival. And there have been studies from specific hospitals, some of which I'll refer to in the presentation. There are also national data sources like data sets from the ONS that can be used to look at mortality and survival, including during the COVID pandemic. So there are other aspects that we can also look at in terms of hospital admissions, what is the frequency, and that can be done for specific sub-regions or parts of the UK. We can look also, which is of growing interest, cost of care and resource usage, particularly for pharmaceutical companies when they develop new treatments, including gene therapies, which are very expensive. How do they justify those high price tag? And also an issue which is growing, which is comorbidities, as the population of sickle cell disease patients are aging. So as I said, these vary in space and time, and that's kind of important to monitor. So coming back more specifically, and you know this probably better than I do, data from the newborn screening programs, we know that it's about 250, 300 births affected with sickle cell disease per year, and thalassemia. That's data, the latest report from the NHS screening program was published in 2016-2017. So it's about 1 in every 2,000 live births in England. The next step was around prevalence and quantifying the number of patients affected with sickle cell disease, and that was a really interesting paper published a few years ago, including David Rees and Baba Inusa. And the conclusions of the paper, or the starting point, were very striking, starting by saying there is no reliable estimates of the total number of people living with sickle cell disease in the UK, which didn't surprise me. but it's a bit depressing for on the global perspective when you think that in England or in the UK we have the NHS, which follows most patients across the country. We have a newborn screening program which has been set up quite early on, and still we don't know how many patients have sickle cell disease. So those researchers and clinicians have pulled data from several national databases and estimated about 14,000 people living with sickle cell disease in the UK, which is equivalent to 1 in 6,600 people. So that's a crude estimate. You can see it's not a precise number. There is no uncertainty or confidence intervals, but it's a ballpark figure, which is sort of better than nothing, and also a higher number than what we have in the cystic fibrosis registry, for example, which is about 12,000 people with cystic fibrosis. It's not the only country where that's an issue, as I've flagged, and there was a paper a few years before the paper that I've just shown, published by Catherine Hassel in the US, trying to do the same exercise, reaching the same conclusions. The number of individuals with sickle cell disease in the United States is not known. Again, it's a high-income country with a universal newborn screening program. They've got good census, good population data, good mortality data, and still we don't know how many individuals have sickle cell disease in the US. They estimated that it was around 100,000 and probably somewhere between 104,000 and 140,000, but concluded also that, again, it varies between states. Another interesting trend that we can look at, so I've mentioned that things vary over time, and we're all aware of that, and over space. So this is data published by some of our colleagues at Imperial from primary care, looking at hospital admissions for sickle cell disease over a period of time up to 2009-2010, and showing an increase in admissions in England and particularly in London. So you can look at spatial variability as well. And in terms of spatial variability, this is also highlighted in some of the data from the newborn screening program, where you can see here changes in the number of babies identified with a significant condition per 1,000 babies between 2005-2006 on the left-hand side and 2010-2011 on the right-hand side. So what these two maps are showing is that it used to be quite concentrated in London, but over time there is a spread of these patients affected with a significant condition in different parts of the country, which has implications in terms of their management and treatment. Now, going out beyond the UK and trying to slowly expand, if we focus on high-income countries, here I've got prevalence estimates which have been published for 4 different countries. I've mentioned the US and the UK already. So the UK, the estimate was about 22 individuals affected per 100,000 population, so that it's comparable measure, a measure that you can compare between different countries. In the US, the work that was done estimated that it was about 41 per 100,000, so substantially higher than what we've got in the UK. There was a recent paper looking at data from France based on hospital records, and they estimated that it was about 49 per 100,000, so substantially higher, and that's not only continental France, not overseas territories, so higher than overall in the US and substantially higher than in the UK. I think it might be a slight overestimate, but that's up to debate. And I've included Sweden also because that's highlighting some of the changes in the distribution of sickle cell disease globally that we've seen over recent decades, where there were virtually no patients with sickle cell disease a few decades ago, and now they've got about 6 per 100,000 population. So this shows some of the variations within high-income countries, and I haven't touched on low-income countries yet. The other element that I've mentioned in my introductory slide about epidemiological indicators or indices is mortality survival. We know that nowadays survival in children with sickle cell disease in the UK and in the US is almost as good, if not sometimes better, than in the general population or in general births, because they are closely monitored, and I think in some really high quality settings their survival is sometimes even better. But when we looked at mortality in Africa, and I'll touch on that later on in the presentation, the survival was much lower, and we estimated, based on a review of the literature, that between 50% and 90% of births died in the first 5 years of life, which has been widely used since we published a paper 10 years ago. So that was a sort of setting the scene in terms of epidemiological indicators. And when we look at the global epidemiology, what is striking, this is data compiled from, again, a systematic review of the literature and pooling data from 1,200 surveys from all around the world, and using a Bayesian modeling framework to sort of fill in some of the gaps. What's clear is that there is a global distribution of sickle cell disease, but that the areas the most affected are, as we know, in Sub-Saharan Africa, in parts of the Middle East, and in the Indian subcontinent. This is another way of showing the same data. This was a map for sickle cell disease allele frequency around 2010. This is a map of the same data for 2015, but at the national level for countries, so that it's easier to sort of visualize. And again, what's striking is that the countries the most affected, the three most affected countries, are Nigeria, the Democratic Republic of the Congo, and India, with Uganda and Tanzania also being in dark red and highly affected. And this can also be shown in a more fancy way with what is called a cartogram here, where you blow up areas which are more affected than you would expect based on their population and country size. So you can see here again that Nigeria, the Democratic Republic of the Congo, and India are blown up much higher than most of the other countries. And what's clearly coming out of this map is that Sub-Saharan Africa is the dominant player in terms of births affected by sickle cell anemia. So this is estimates of births affected by sickle cell anemia. It's much harder to go from birth estimates to population-wide estimates across all ages, because we have a lot of uncertainty around mortality. Now, I can present these similar data in a table by country for the three most affected countries, or by region, and this is just to put things in perspective. When we think about sickle cell disease and the births affected in the UK or in Europe, it's about 2,000 births affected by sickle cell anemia, not sickle cell disease, specifically sickle cell anemia. So that's 0.6% of the estimated number of global births affected across the world. The vast majority of these births, 77.6%, are based in Africa, and that was based on estimates in 2010. What we looked at also was what would happen in the future based on demographic projections. So we know that fertility in Africa and India is much higher than what we have in Europe. Populations are starting to decrease and age in Europe. So the vast majority of the changes in the future will occur in Sub-Saharan Africa. And what we've concluded is that these trends and this higher representation of births affected with sickle cell disease and sickle cell anemia will reinforce itself, and that the countries most affected and the regions most affected will become even more proportionally affected over time, with 80% of sickle cell anemia births in the world coming from the African region. So that's put things in perspective compared to the number of births affected in the UK or in Europe. Now, Sub-Saharan Africa, we hear a lot about it, and I mentioned it to Ralph before the start. It's not only coming out of sickle cell disease, it's not only striking in terms of sickle cell disease burden, but it's also the areas which tend to be the poorest. They tend to be very challenging in terms of rolling out health interventions. So this is recent data on COVID vaccine doses per 100 people, we can see really high rates in most of the world. But what's striking here is Sub-Saharan Africa, where it's been a lot more challenging and resources to allocate the vaccine have been much more limited. And then they are facing a lot of other challenges in terms of health as well, particularly with infectious disease, HIV, but also malaria, which is a kind of nice loop or nice circle, because obviously the distribution of sickle cell disease is closely linked to the distribution of malaria and the level of malaria endemicity, as we've shown a few years ago. So that was my sort of quick overview of the global epidemiology of sickle cell disease. There is a lot more work that needs doing in this area, and a lot of it might be possible or made possible through new developments, including in terms of point of care testing devices. So what are they? And we've heard a lot about point of care testing devices for COVID, and I'll come back to that. But I wanted first to give a sort of nice anecdote about the challenges of screening for sickle cell disease in Sub-Saharan Africa. And that's based on discussions I've had with Obi and Nodu in Nigeria a few years ago. And she mentioned an initiative from the National Federal Ministry of Health in Nigeria. So quite high level, and they decided as part of the Millennium Development Goals to establish 6 excellent centers for sickle cell disease across the country, where they could screen for sickle cell disease and collect all the samples from each of the regions. And they wanted to start this in 2011, 2012. So they I think with some sponsorship from companies and possibly support from high-income countries, they equipped each of the center with an HPLC machine, so high tech. They developed a national protocol. So far so good. It looks like very encouraging. 20 years ago, they wanted to set up a national program. What's a lot more depressing is that by 2017, the numbers of babies screened was fewer than 2,000 across those 6 centers. And so they reflected on what had gone wrong, and despite the substantial investment that had been made originally, the main challenges were that there was no specific budget allocated to run these centers. The staff was poorly trained. A lot of the regions expired because they didn't have samples to test. Consumables for these high-tech machines were limited in terms of availability, and one of the key challenges in many settings in Africa is that the power supply was very erratic. So they probably lost a lot of samples even when they tried to collect them. And the other challenge was that having those key centers to centralize samples, there was no mechanism to formalize that. So it was a lot on an ad hoc basis and didn't really work. Now, I've mentioned point of care testing devices for COVID. We all use them on a regular basis nowadays. We are probably swabbing ourselves a lot more frequently than ever before, and a lot of the population wasn't aware of those small, cheap, easy, portable devices that could give a diagnosis very quickly. The concept for sickle cell disease is the same, and there have been 3 main devices on the market over recent years, all looking very promising. Sickle Scan was the first one, produced by Biomedomics, and you can see on the right-hand side in the top of the slide what it looks like. It's very much like the COVID lateral flow tests. And it's straightforward to read. I should have mentioned it works with a drop of blood rather than kind of a swab like for COVID, obviously. But that's it's really, and I'll come back to it, really sensitive, specific, easy to use. The other one is Hemotype Sc, also produced by a company in the US, Silver Lake Research. And this one, you can see on the right-hand side in the bottom, is a bit trickier to interpret and less intuitive to read. So we've had situations with staff in Nigeria doing pilots where they needed to be trained very specifically on that one, because reading the test results can be quite challenging. And then there is another one which is slightly different, which was called Hemotype originally, and they've rebranded it as Gazelle HB variant. And that seems to require a specific cartridge and a specific machine to read the cartridge, but it also quantifies each one of the hemoglobin variant found. So you can see in the screenshot on the right-hand side that it identified in that sample 42% of HbS and 58% of HbA normal hemoglobin. So all these devices are coming on the market quite fast, and obviously they've been assessed by clinicians and researchers in the field, in lab work, and they are really promising in terms of what could be achieved with such devices. So obviously it could save lives through early diagnosis, because we can't prevent complications and save lives in Sub-Saharan Africa if we don't know who's affected by sickle cell disease. So screening is the first step. These two papers include summary tables of the characteristics of these POCT, point of care testing, or POCD, point of care devices. And they are very helpful. So here is the summary from Dexter and McGann, showing the three main tests that I've shown: Hemotype Sc, Sickle scan, and Gazelle. And you can probably not read the details, but you can see that there've been field validation for each one of these tests in various countries, and you can see specificity and sensitivity measures. I'm always a bit dubious about sensitivity reported as 100%, partly because those companies are supporting some of these field validations sometimes want to demonstrate really high sensitivity and specificity so that they can gain access to markets. So sometimes they seem too good to be true. So in summary, the advantages of point-of-care testing devices are that they are low cost. I think they used to be about $1 per test, but bought in bulk, they are probably much cheaper nowadays. They are reliable. There was a lot of questions about their reliability in the past. Now there is more and more evidence showing that they have high sensitivity and high specificity. They are very easy to use, that they don't need long complex training for the staff to use them. They don't need to be medically qualified. They just need to be familiar with how the test can be read and how the test can be done. They are very easy to store and transport. So then there is, again, which is an important factor, no need for a cold chain, reagents, or electricity, which was one of the main limitations with the HPLC machines or previous setups. They give really rapid results within minutes rather than hours and days. They can give results locally rather than having to be sent to a lab and then passed back on to the patient tested. They are easily portable and lightweight. And I should have mentioned also that they don't only detect sickle hemoglobin, they can also detect hemoglobin C, and whether you're a carrier or affected by the disease. So there's been a lot of work trying to demonstrate how easy to use they were and how inexpensive they are. This is an example of Charles Quinn's work showing that they are rapid, inexpensive, and disposable. Disposable being potentially an environmental problem, and we see that with COVID tests, lateral flow tests in the UK, with massive consumption. It's a large consumption of plastic and all the packaging associated to it, but it's a balance of benefits and impact, and they could be particularly useful for sickle cell disease in low income countries and low income settings. Are they scalable? Because all these pilots usually have been done on a few hundreds, a few thousands individuals, and we've done work again in Nigeria where there is the largest population affected. So we concluded that it was scaled up, it could be routinely used, it was well accepted by local populations, and it could be applied to large numbers for all the reasons that I've described before in terms of simplicity of use and not requiring highly skilled staff to use them. This is some of the work that we've published again with Obin Nodu, trying to not reinvent the wheel and building on infrastructures that are existing already. So in this case, it was using primary healthcare immunization programs for HIV and using those settings and those facilities to add the testing, the screening for sickle cell disease, and we found it was doable, reliable, accurate. We also compared the results of those sickle scan devices with results from HPLC testing that was done in parallel, and again found high accuracy and reliability, and to the point that it's been put forward for a Nigerian-wide demographic health survey, so a DHS. And demographic health surveys are conducted in most low and middle income countries on a regular basis, 5 years, every 5 years, 10 years. It's the rough equivalent of the census in high income countries. And they aim to provide a nationally representative sample. And that was the first Nigerian DHS in 2018 to include screening for sickle cell disease. So they looked at 42,000 women across 40,000 households across the country, and the sampling was designed so that it would be representative. And they picked a third of these households and screened all the children in those households for sickle cell disease. So about 11,000 children screened for sickle cell disease. And that's really useful data set because there is data on sickle cell disease across the whole of Nigeria, but it's collected in parallel with a lot of data on fertility, on malaria, on socioeconomic status, which is really valuable. They used for that sickle scan, which is one of the point of care testing devices that I've mentioned. And again, it was considered highly reliable and scalable. And that generates data that can be used then to refine some of the epidemiological indicators that I've mentioned before. For example, looking at child mortality and how it varies across different parts of Nigeria. They have, as I said, a high sensitivity and specificity, and despite some of these studies having been conducted in the lab in the US or some fieldwork in Sub-Saharan Africa, new studies keep coming up to support this. This was a study from India on Hemotype Sc, again showing high specificity and high sensitivity. Now, what you might wonder now is, like, what is the use of these point of care devices in high income countries or for use specifically in the UK? Is there any use, or is this particularly relevant for low income countries and countries with the highest prevalence? Because the focus was on the global epidemiology. I think there is, and as I've shown, the vast majority of births affected occur in Sub-Saharan Africa and in India. I think there is a lot of scope for their use in those settings, but I also wanted to come back to the UK and high income countries and you and your work and see if there was any possible use. And so we've all seen the headlines about, for years and years, migrants influx in Europe and in the UK, and they tend to come from various regions in Sub-Saharan Africa, in the Middle East. It's quite complex fluxes. It varies over time. It was a lot in the media in 2015 with the Syrian crisis and what was called the European migrant crisis. And we've done some work with a team of Italian collaborators at the time, where there were hundreds of immigrants or refugees coming on the coast of Italy, and inevitably several of them on a daily basis or on a regular basis being affected by hemoglobinopathies, not only sickle cell disease, also thalassemia. And so there were a lot of thinking with charities looking at those refugees at the time about how to prevent some of the complications in patients with hemoglobinopathies and how to prevent deaths even ultimately. And so we did some work with Lucia Di Franceschi and other colleagues in Italy around access to emergency departments, and those point of care testing devices could be part of the solution to rapidly screen large number of refugees coming in camps, quite often in specific locations. Possible other applications that again are up for debate is that with a globalization of the distribution of sickle cell disease, there are regions where there aren't many patients, there aren't many highly specialized hematologists or staff trained to recognize sickle cell disease and to understand sickle cell disease. So in some settings where there is a very low prevalence or very small number of patients affected, it might be an efficient way of identifying or regularly testing some of the patients, probably in those of older ages, particularly if there is a universal newborn screening program. But it might be a useful tool to use to confirm suspicions in some of the patients. It raises questions about targeted versus universal screening that we've seen in the newborn screening in France. So there is some controversy around that. And it could be used in possibly Scandinavian countries and other countries where the prevalence is much lower, as I've shown earlier. So I think that's my presentation wrapped up. There was quite a lot of data, quite a lot of information in there. Hopefully it was helpful. There is my email address at the bottom, my Twitter handle if needed, and I look forward to some interactions with questions now. Thank you.
Thanks so much, Fred. That's great overview and update on the progress towards neonatal screening in countries where that really matters. I'm sure there'll be other questions, but can I ask, given the very high childhood mortality in Sub-Saharan Africa, clearly neonatal screening is only part, albeit an essential part of the remedy, and it will be necessary to scale up services that can deliver effective interventions, penicillin prophylaxis, and so on. To what extent is that evolving in parallel with developments in neonatal screening in low resource settings?
So that's a very good question, Mark, and I think it's important when we talk about Sub-Saharan Africa. It's a very heterogeneous set of countries, set of regions. There is, and there are high quality healthcare settings in centers of excellence in Kenya, in Tanzania, in Nigeria, where healthcare and identifying the babies affected is quite routine or nicely done. So there is a lot more focus nowadays on how to reach the large numbers in rural areas, go beyond targeted efforts in cities, and so the first step is, as you said, screening and identify the babies affected. The next one, even before you can deliver interventions, is to keep track of the work you've done, because if you go to rural areas, you do use these point of care testing devices and identify patients, but then you don't have any records of it. If you come back a month later, you've got to start from scratch again. So that's really one of the challenges, to kind of identify the babies affected and then finding a way of keeping a record of it, which again, when we are used to the NHS having our NHS number, everything being informatized, digital, and having digital records, is straightforward in high-income countries, but is a lot more challenging in those settings. So that's where keeping track of these records is very important, and then delivering those interventions. And I think it's been very encouraging to see in Ghana and in Nigeria some national level initiatives supported by the Ministries of Health, and identifying sickle cell disease as a priority and trying to put in place measures at the national level where it's supposed to be equitable for everyone, and that's encouraging. I think it's nice to suggest it's going to be implemented on paper. Given the numbers at stake, I think it's going to be very challenging, but it's heading in the right direction.
Thanks, Fred. So if there are any questions that people would like to raise their hands or put the questions in the chat, and I'll read them out. Given the number of affected births in Sub-Saharan Africa, Fred, the need for infrastructure to provide long-term care is going to be very, very considerable, isn't it? If you improve childhood mortality even by a relatively modest amount, the support that will then be needed on a lifelong basis is going to be quite a burden on health systems that are strained.
And that's the irony of it, or the sort of that. In some ways, if you intervene and if you identify the babies that are affected, then you've got to supply to be able to manage their condition and look after them. So I think that's kind of, a lot of people are well aware of it. Some would argue that the best prevention would be to avoid those births and have quite strict genetic counselling and avoid carriers to marry each other, and that's a debate. Again, on paper, yes, it's the option that makes more sense, instead of trying to improve the survival of those babies and managing them throughout their lifetime. Preventing their births would be probably a better solution, but then there are many other aspects. So I think it will be progressive. We won't change dramatically the survival across the whole of Sub-Saharan Africa over the coming years. So hopefully we'll learn from lessons from pilots in various regions about how we can do it. And I think, again, building on existing infrastructures and not working solely with sickle cell disease or hemoglobinopathies in mind, but working with people working on malaria, HIV and other important health issues in those settings will make it a lot easier. If there are vaccination campaigns and you can give hydroxyurea at the same time, or again, hydroxyurea daily pills are probably not the ideal for those settings. So there are developments that could possibly in the midterm or long term have a big impact.
Yeah, thanks. We had a very interesting talk from Pat McGann last week, who was describing some of the hydroxyurea studies that have been completed in Africa, and also the considerable benefit that hydroxyurea is now having in the pediatric sickle cell population globally. And I suppose that is a relatively low cost intervention, and coupled with penicillin prophylaxis and vaccination. Going back to Graham Sargent's work in Jamaica, relatively simple interventions had a huge impact on morbidity in children in a positive sense.
Yeah, absolutely. I think there have been some international cost-effective or cost-benefit analysis of those interventions, and largely showing that they would be cost-effective in those settings. So there is some evidence. It's sort of getting the funding to roll them out, and then the infrastructure and building on existing initiatives.
Thanks. There are a couple of questions in the chat. One is based on population predictions. What are the estimates in terms of increasing affected births, particularly in those countries where sickle is prevalent?
So that's one of the interesting questions we wanted to answer a few years back when we and it's partly, I didn't cover the numbers here, but I had the privilege of working with Professor Weatherall for various years, and he always warned about the increasing burden of hemoglobinopathies globally. But there was no quantification of what that increase might be, and so when we looked at the estimates, and that was thanks to the Bayesian modeling framework that we had in place, and we had the map that I've shown before, we could estimate the number of annual births affected in 2010, which is shown here as a fancy cartogram, and that was about 300,000 annual births affected with sickle cell anemia. Again, it's only sickle cell anemia, because to look at sickle cell HBSC disease or HBC thalassemia disease, we would need good data on either hemoglobin C or thalassemia as well, and we didn't have that at the time, and we still don't have them. We have good data on HBC distribution, but the thalassemia is detailed data on the distribution of alpha and beta thalassemia are still missing. So that's why we just looked at sickle cell anemia births. And our estimates for 2050, and again, it's just ballpark estimates. You can see the confidence intervals, confidence limits from 242,000 to 657. That's really wide, but we are talking 2050, so that's still almost 30 years away from now. The annual number of births was 400,000, so an increase of 100,000 over 4 decades, which is really substantial.
Yes, thanks. And another question from Miriam Munoz Diaz in Newcastle, asking about data on life expectancy of sickle cell disease in the UK, which is something that's been talked of a lot without any very concrete or good data, I think.
I think again it comes back to the challenge of when we don't know exactly how many patients we have and where they are. It's hard to know what the representative national life expectancy would be. I think that there is an understanding that the life expectancy has considerably improved, as we mentioned, in the UK over recent decades, but it's still lagging probably 2 decades compared to the normal population. Having specific estimates of life expectancy, I'm not sure there are recent data. Someone suggested Kate's paper, but it's again because things change over time and space. It's something that needs to be monitored on a regular basis, probably not on a yearly basis, but every 5 or 10 years needs to be revisited and monitored.
Then a question about the point of care testing and the need for follow-up confirmatory testing, which is something, of course, that we do routinely in the UK.
I haven't seen that coming up as a major question so far in those settings, because I think there is so much to be done to first identify the baby is affected, that kind of confirming I think in some cases they can't get a reading, so they might collect an extra sample and send it to a lab for validation. When we did look at comparing results from POCTs with HPLC, the results were very consistent. There was the need for a secondary validation, given the numbers, what possibly researchers locally could envisage, unless it's a specific case that can't be captured by the tests. And as I said, they've got a difficult reading, but it is to screen multiple times. And I think I've mentioned the issue of monitoring and following up patients and individuals. But if those devices are so easy to use and so cheap, it might be easier to retest someone if you have a doubt, even if they screened negative in the past, to rescreen them again with the same test or a different test, or to send a test to the lab if you want to confirm. But I think given the size of the numbers of babies they want to screen in those settings, and the limited resources, I don't think there is any plans at the moment to have secondary confirmatory testing in place.
Thanks.
At least systematically.
And is there any plan to you mentioned the what are somewhat unfortunately referred to as prevention programs by the WHO, but the identification of affected birth is obviously an opportunity for secondary genetic counselling and offer of prenatal testing. Is that being considered in any of the screening programs?
I believe it has been, particularly in some of the settings in Nigeria. That's clearly so they are looking at acceptance and genetic counselling, and it's a full approach, being aware of all the implications. There are discussions in India as well, where there are still a lot of arranged weddings, and so genetic counselling could be a part of that as well, building on screening programs.
Thanks. Well, if there are no more questions, just remains for me to thank you again, Fred, for that great talk. I think we all learned a great deal from it, and look forward to inviting you back in a year or two's time once you're able to travel to Sub-Saharan Africa again.
Great, thanks very much for having me. It's been a pleasure.
Thanks very much.
Thank you.
Thank you.
Bye-bye.